Hi, I'm Dr. Ben Dodd. Good morning. Today we're going to talk about weight loss surgery complications. Weight loss surgery should not be undertaken lightly, in that there is always a balance of the small potential risks at the time of surgery and potential for late risks that has to be balanced against the potential benefits. Now, weight loss surgery in 2024 is extremely safe in well-trained and attentive surgeons' hands, with the risks of major complications in the order of 1 to 2%. If these complications happen, then in the context of patients who are watched very carefully post-operatively, whilst they can result in returns to the operating theatre or other endoscopic or radiology, that is X-ray based interventions, they are very rarely going to result in patients becoming so ill that they have to attend an intensive care unit or worse. Complications that we can see from time to time are leaks, not so much from the anastomosis or join, for example in a gastric bypass, but as you're probably aware, in doing these modern weight loss procedures, we use very advanced, fine, 10mm wide stapling devices that go down the laparoscopic keyhole ports and allow us to either staple off the outside part of the stomach, as in a sleeve gastrectomy, or in the case of a gastric bypass, to create a smaller stomach or gastric pouch. Now, these stapling devices, as I say, are very advanced. They generally deploy 3 rows, or 6 rows rather, of staples, and between those 6 rows, 3 rows on either side, a knife device cuts through between the staples, hence stapling off on either side of that cutting line. Those stapling devices are very advanced, but despite that and our surgeons' best efforts, those staple lines can very rarely leak and necessitate a return to theatre in the first post-operative week. Bleeding is obviously a risk of all major operations. With careful surgery and with other adjuncts to minimise bleeding, the chances of return to theatre are extremely small for this. Things such as wound failure and hernias through port sites or bowel obstructions from this, also exceedingly rare, in the order of 1 in 1,000. Leg clots and lung clots have historically been a problem for bariatric surgery, but those risks have dramatically reduced in recent decades because keyhole surgery is now much more advanced and refined, and these operations are now, certainly in the primary context, usually taking much less than an hour. So the chance of developing a clot in that anaesthetic downtime is much reduced. Furthermore, our understanding of the clot or the precipitators of leg clots and lung clots is much advanced, and we have modalities such as enhanced recovery after surgery, where patients are facilitated to get out of bed, start drinking soups and getting up and breathing deeply and moving around very normally, often within just 1 hour of surgery. And this enhanced recovery after surgery, or ERAS principle, really does dramatically reduce the risk of patients developing harmful clots. So those are the sort of main risks. At the time of surgery, infection, in wounds is extremely rare. If staple line or anastomotic leaks do occur, then that qualifies obviously as infection, and if that is severe, that can mark sepsis. But these things in the modern era, if patients are watched very closely with a team of doctors and nurses following the patients carefully, then missed complications are extremely unlikely. Now on to the longer term complications of bariatric surgery. These can be considered in different ways. Any procedure that alters the stomach, that is any bariatric procedure, increases the resistance to swallowing pipe emptying. So all of these procedures do have the potential for creating reflux in the longer term. Classically, the sleeve gastrectomy and the gastric band have been particularly reflux-provoking procedures. I don't myself perform lap bands anymore because I don't believe they have a role as they used to 20 years ago. I think modern sleeve and bypass is far superior and far safer than it used to be. And sleeves, which did historically have a 1 in 4 risk of substantial reflux problems long term, that just is not the case anymore, in that modern sleeves are shaped differently, and so they are far less reflux provoking. The gastric bypass options of Roux-en-Y and single anastomosis or single limb gastric bypass, they can also both cause reflux, but the numbers are far superior to that of a sleeve. That is in the order of between 2 and 4% in primary cases on a long-term basis. Any procedure that precipitates weight loss or weight loss operations do have a risk of gallstones long-term, simply because of the weight loss. That is in the order of 7%. That's got to be weighed up against the high risk of patients in the community not having weight loss surgery developing gallstones on their own. In any case, if this does happen, removal of the gallbladder is extremely safe in 2024. Historically, weight loss surgery was associated with a lot of malabsorption, particularly the gastric bypasses. Even just 10 years ago, we were bypassing a lot more small intestine, and with the bypasses, one of the benefits of the bypassing of the small bowel is that you get more assistance with your weight loss long term over a sleeve. Historically, that was associated with too much weight loss in some cases, or too much malabsorption, and that could result in diarrhea or hair loss or vitamin mineral deficiency or excess weight loss, and in some large series, patients did have to have their weight loss surgery reversed because of excess weight loss. With the modern version of the Roux-en-Y or single limb bypass, that simply is a very, very, very rare outcome, because we now bypass far less small bowel, about half what people were doing sort of 15 odd years ago, because we know that that is not necessary to facilitate very good and durable weight loss, but it does cause much greater side effects. So the modern version, that is simply a much rarer complication. Weight regain is a risk of all weight loss surgery. Weight loss surgery is not magic. These operations are all very, very good at what they do, but they are not perfect, and they always have side effects, potential for side effects, and they will not keep the weight off if patients don't see weight loss surgery for what it is, which is a tool to reassess and recalibrate your eating habits so that you can exist as a lean person in our modern obesity-provoking environment. And if that's the case, then weight regain should be a thing of the past. Other complications that can happen from weight loss surgery, usually most commonly seen with a Roux-en-Y gastric bypass, is that chronic abdominal pain can occur because of the second join of the Roux-en-Y over the single limb bypass. And other problems such as bowel obstructions because of the complexity of bringing the intestine up into the upper abdomen onto a gastric bypass pouch. That can create artificial windows that bowel can get stuck inside. And so very occasionally we do see bowel obstructions following gastric bypass surgery, particularly the older-fashioned Roux-en-Y. And then dumping is a symptom for patients that can exist in different forms, but most commonly is where patients experience abdominal cramps and sweatiness and occasionally diarrhea and lightheadedness. And that's not commonly seen in sleeves, but it's a consequence of having undigested foodstuffs in the small intestine. And it's most commonly seen after Roux-en-Y gastric bypass, where deliberately the digestive enzymes are separated from where the food enters the small bowel out of the stomach pouch. So those are the main bariatric complications. They're all extremely rare events in the modern versions of these operations, but they can potentially have significant consequences. So safe bariatric surgery is about watching patients very carefully in the first 2 weeks post-operatively to ensure all complications are picked up very early. And as long as they're picked up very early and managed assertively, safely, correctly, then patients come to no harm. The later complications are why we do need to keep patients on multivitamins and do blood tests every 3 months or 6 months generally in the first 12 months, and that can be spaced out when patients' weight loss is generally slowing down. But we do like to watch patients for 5 years post-operatively, simply to keep all these complications at a minimum long term. Thanks for your time. I look forward to answering any of your questions when I meet you in person.